Welcome to our session on the key components of complexity-based evaluation and management. This session is going to focus on medical decision-making, which is one of the three key components used to meet a complexity-based service. You will want to review the other sessions for history and exam, which are the other two key components for reporting a complexity-based E&M code. My name is Stacy Olson, and I'm a certified professional coder with a specialty credential in E&M services through the American Academy of Professional Coders. CPT is the code set that is used to report professional medical services, and evaluation and management codes are included in CPT but are a small portion of the code set. CPT codes are developed, maintained, and copyrighted by the American Medical Association. Every attempt has been made to provide you with accurate and current information, but the coding rules can and do change, and it is always the provider's responsibility to know what the state and federal rules are and to remain current on payer policies. Today's information is not legal advice or a reflection of any individual health system's policies or procedures. It is meant to inform you of general knowledge and best practices for billing and documenting medical services. Our objectives for this session will be to define the three elements of medical decision-making as outlined by CMS documentation guidelines and CPT. We will calculate the level of medical decision-making for a case study using the auditing tool provided by WSPA, and will illustrate the E&M codes that would be supported for the level of medical decision-making that we obtain. Providers can correlate medical decision-making to the assessment and plan in their progress notes. Medical decision-making refers to the complexity of establishing a diagnosis and/or selecting a management option. Medical decision-making is calculated based on three elements: the number of possible diagnoses and/or management options that must be considered, the amount and/or complexity of data to be reviewed, and the risk of complications, morbidity, and/or mortality. To obtain the overall level of medical decision-making for a given E&M code, we must meet or exceed two of these three elements at the same level. Some organizations may choose to make medical decision-making the overarching criteria for selecting an E&M code because they feel this can help to minimize the organization's overall risk. And generally, if you are basing the code on medical decision-making, you will meet medical necessity for the service. However, CPT states that two of the three key components are needed to report an established patient or subsequent facility visit, and there are organizations that do allow E&M codes to be billed based on history and exam levels alone. The four levels of medical decision-making are in the bottom row of this table. They are straightforward, low, moderate, and high. The three elements of medical decision-making are listed on the left, with diagnosis and management options in the purple, amount and complexity of the data in blue, and the risk in green. In each of these elements, there are four different levels that can be reached, which are listed in the same row as the element. CMS uses different terms for the second, third, and fourth levels for some of these elements, but to simplify things, you can think of any element as being straightforward, low, moderate, or high. This will line up with the medical decision-making in the last row. For instance, you can think of extensive as being equivalent to high. We see that there is a number assigned in some of the sections on this table. This number is a mathematical way of analyzing a provider's documentation to define what is minimal, limited, extensive, moderate, and high. This concept is from the Marshfield auditing tool that is used by most organizations when coding or auditing provider documentation. 4 points is the maximum amount of points that can be calculated in any of the elements. Providers may have more than 4 points documented, but for coding purposes, we stop counting at 4. The first element that we are going to discuss is diagnosis and management options. Credit should be given in this section for the diagnoses and/or the management options that are pertinent to the patient's presenting problems or the signs and symptoms. These are the problems that are being monitored, evaluated, assessed, or treated during the encounter. There is greater consideration given to problems which have not yet been diagnosed and whether this is a new problem to the provider or not. The Marshfield tool assigns a certain number of points to the types and statuses of the problems that are being addressed. Self-limited or minor problems are assigned 1 point for each problem with a maximum of 2 points. These are generally thought of as problems that would resolve on their own without seeking any medical attention. Established diagnoses that are improved, well-controlled, or resolving are worth 1 point for each problem. Established problems that are inadequately controlled, worsening, or failing to change as expected are worth 2 points for each problem. New problems without workup are worth 3 points, with a maximum of 3 points assigned in this category, and new problems with additional workup planned are worth a maximum of 4 points. Additional workup planned refers to diagnostic testing or consultations which will be obtained either during or following the encounter for the problem. It is important that you do not confuse new problem here in medical decision making with new patient visit E&M codes. Organizations may define new problem differently. The Marshfield tool states that credit is given as new problem to the examiner. The Marshfield tool is designed to give providers credit for the complexity of their thought processes. It gives more credit for handling a problem that the provider is seeing for the first time, even if that problem has been previously identified or diagnosed by another provider in the same group. However, some organizations have policies in place that state new problems are new to the clinic or group that the provider is working with. They don't feel it is appropriate to potentially bill a higher level of code to the patient because a new provider in the clinic is seeing them for it for the first time. If you are working with a healthcare system, check with your organization to see which of these rules they follow. If you are just getting started and your organization doesn't already have these policies in place, you will want to make a decision about how points for new problems will be credited. The highest number of points achievable is 4. Points are added together for each problem. So if you have 2 stable established problems and 1 established worsening problem, you would have a total of 4 points, which is the maximum you can obtain. This scoring methodology is not part of the 1995 or 1997 CMS guidelines or from CPT. However, some Medicare contractors do use a similar methodology. Noridian, which is the CMS contractor for Washington State, has never released the tool that they use for determining if an E&M is supported. Each encounter needs an assessment, impression, or diagnosis documented. CMS states it can be explicitly stated or implied in documentation regarding management or further evaluation. I strongly recommend that providers explicitly list all of the conditions being addressed in their assessment. Most EHRs will have the provider select a visit diagnosis code, which will populate into the note, but the provider should still explicitly list the conditions in their assessment as best practice. When a patient has an established diagnosis, the provider should state whether that problem is controlled, worsening, stable, failing to change, etc. By documenting the status of the problem, you remove subjectivity from others about where the problem should be credited. Clinical impressions may be stated in the form of a differential diagnosis, such as rule out, probable, suspected, consistent with, etc. However, we do not report the ICD-10 code for differential diagnosis until it is confirmed. ICD-10 codes for the signs and symptoms that are being worked up would be reported instead. You should be sure to document any initiation or changes in treatment, and if you make any referrals or request a consultation for the patient, the record should reflect where the patient is being sent. If you don't know the specific provider that will be seeing the patient, at least state the specialty that you are sending the patient to, such as cardiology or PT. The amount and complexity of data to be reviewed is based on the diagnostic testing ordered or reviewed, and also decisions to obtain records or history, or the actual review and summary of records and obtaining history from someone other than your patient. Again, the provider is credited points for the work in this section, and the maximum accumulative total is 4 points. Reviewing and/or ordering lab tests is assigned 1 point. Reviewing and/or ordering radiology tests, such as X-rays or DEXA scans, is also assigned 1 point. Medicine tests are also worth 1 point. Medicine tests are the tests that are included in the CPT chapter titled Medicine. This chapter includes a wide range of testing such as audiology tests, EKGs, echocardiograms, nerve conduction studies, and polysomnographs, to name a few. 1 point is credited in each of these categories regardless of how many tests are ordered and/or reviewed in each category. If the provider orders labs during the encounter and reviews DEXA scan findings and also reviews an EKG report, the provider would receive 3 points in this element of medical decision making. Providers should always be specific about what tests were reviewed and the results of those tests. Some providers will pull the lab values into their chart note, or they might state the DEXA scan from June 22nd was normal. Either of these types of documentation are acceptable to receive the points in these categories. Next, we have discussion of contradictory test results with the provider who performed or interpreted the test. This is assigned 1 point. Documentation should state who the conversation was with, which test was being discussed, and a brief summary of the conversation. Documented decisions to obtain and review old records and/or a decision to obtain history from someone other than the patient is worth 1 point. This point is credited for the provider documenting their intent to get records or history from someone else. For instance, the provider might document, "I will obtain records from the patient's previous PCP," or "I will call the patient's daughter for additional history due to the patient's severe dementia." The next category in this element is independent review of an image, tracing, or specimen to supplement information. This is worth 2 points. This category differs from the 3 categories at the top of the table that are worth 1 point because the provider is independently or personally reviewing the image, tracing, or specimen. To receive credit for this, the provider should document that they personally reviewed the image, tracing, or specimen, as well as a summary of their findings. The last category in this element states providers will receive 2 points when they review and summarize old records and/or obtain history from someone other than the patient. To receive 2 points for review and summary of old records, the provider should state the source of the records reviewed and summarize the information that was obtained which is relevant to today's encounter. These may be hospital records, other specialist records, old records from previous healthcare providers, and in the instance of children, school records or immunization records may count as well. Obtaining history from someone other than the patient should have supporting documentation of who the history is being obtained from and why. My opinion is that this is appropriately credited when providers are unable to get information from their patient, or they are unable to trust the information they are getting. For instance, in a patient who has severe Alzheimer's, it may be difficult for the provider to obtain history from the patient, and instead that history may need to be obtained from another family member. I also will usually credit the provider if an interpreter is used to obtain history during the encounter, as this complicates the service as well. The last and third element of medical decision-making is the risk of significant complications, morbidity, and/or mortality associated with the presenting problems, the diagnostic procedures ordered, or the possible management options. Comorbidities or underlying diseases and other factors that increase the complexity of medical decision-making by increasing the risk of complications, morbidity, and/or mortality should be documented. If diagnostic testing is ordered, planned, or scheduled at the time of the E&M encounter, the type of test should also be documented. Because determining risk is complex and not readily quantifiable, CMS and the AMA put together a table of risk that includes common clinical examples rather than absolute measures of risk. There are 4 levels of risk: minimal, low, moderate, and high. Within the table, there are 3 categories: presenting problems, which is based on the risk anticipated between the present encounter and the next encounter; diagnostic procedures ordered, which is measured by the risk during and immediately following the diagnostic study; and the last category is management options, which is based on the risk during and immediately after the treatment. The highest risk in any category is the overall risk for the encounter. So let's say that the patient's presenting problem falls under a low level of risk, but the management option selected falls under the moderate risk. The management option would trump the presenting problem, and the risk for the encounter would be assigned as moderate. Here is the table of risk from the AMA and CMS, which provides us with some clinical examples. Remember that this is not an all-inclusive list, but rather a guide for where certain problems, studies, or treatment should fall. We can see the levels of risk on the left of the slide in green, and the columns for presenting problems, diagnostic procedures, and management options are colored in blue. This section of medical decision-making is not actually assigned a point system like the other 2 elements we just discussed. However, I like to have providers think of it as if there are points assigned to these levels of risk. This makes the concept of applying 2 out of the 3 elements a little bit simpler when we calculate the overall level of medical decision-making. So think of any category in the minimal row as 1 point, any category in the low row as 2 points, any category in moderate as 3 points, and any category in the high row as being 4 points. I know this slide is a bit difficult to read, so let's look at each level of risk individually to see what CMS and the AMA have assigned to these levels. Minimal risk is sometimes referred to as straightforward. The options in bold purple text are options that I think may be pertinent to the problems, tests, or management options that pharmacists would utilize the most. However, just because I have not highlighted an option in purple does not mean that a pharmacist would not be able to receive credit for it. Under our presenting problems in the minimal row, we see one self-limited or minor problem such as a cold or insect bite. Under diagnostic procedures, we see venipuncture labs and urinalysis. And in the management options, which I refer to as home remedies, we see options such as getting rest or gargling. I think in most instances, the presenting problems or the management options will trump the level of diagnostic testing that pharmacists would order. Under low risk in the presenting problems category, we have 2 or more self-limited or minor problems, 1 stable chronic illness, or an acute uncomplicated illness or injury. I have not highlighted any diagnostic procedures. However, there may be some options that could potentially apply to pharmacists. Under the low-risk management options, we have over-the-counter drugs and IV fluids without any additives. The moderate risk presenting problems include one or more chronic illnesses with a mild exacerbation, progression, or side effects of treatment, two or more stable chronic illnesses, and acute illnesses with systemic symptoms. Again, I have not highlighted any diagnostic procedures. However, you can see that they are moving into more complex and invasive diagnostic tests. The moderate risk management options include prescription drug management or IV fluids with additives. Presenting problems in the high level of risk are one or more chronic illnesses with a severe exacerbation, progression, or side effects of treatment, acute or chronic illnesses that pose a threat to life or bodily function, and any abrupt neurologic changes. When a patient has a chronic illness with an exacerbation, progression, or side effects of treatment, the provider should be specific when documenting to include whether that is mild, moderate, or severe. This way, coders and auditors will give you accurate credit for your risk. Under the management options, we have parenteral controlled substances and drug therapy requiring extensive monitoring for toxicity. Providers should state the drug that needs to be extensively monitored, how often it will be monitored, and the method that will be used for monitoring for toxicity. Now that we have reviewed the three elements of MDM, let's look at a few examples to calculate the overall medical decision-making for an E&M code. These examples are very condensed documentation just to give us relevant information needed to calculate the MDM. Example 1 is Mrs. Jones, who is presenting for follow-up of her stable hypertension and diabetes. Labs are ordered for her, and the patient has been feeling well and checking her blood pressure and blood sugars regularly. There are no changes made to her medications. When we apply the methodology we just reviewed to this encounter, the provider would receive 1 point for each stable problem under the diagnosis and management options for a total of 2 points. In the amount and complexity of the data to be reviewed, 1 point would be credited for ordering the labs. And when we look at the risk, we see that the patient has 2 stable chronic problems, which is assigned to moderate risk under the presenting problems category. When we apply the example to the medical decision-making section of the auditing tool, we would fill it out as shown on this slide. We would circle 2 points in diagnosis and management options, as the provider would receive 1 point for each stable established problem. We would circle 1 point under the data to be reviewed for the labs that were ordered, and we would circle moderate risk for 2 stable chronic problems. Remember, to come up with the overall level of medical decision-making, we must meet or exceed 2 elements at the same level. In this example, we do not have any elements that align in the same column. So the level of medical decision-making where we have met or exceeded 2 of the 3 is at low. This is what the lines on the table are showing you, that 2 of the 3 elements have intersected at low medical decision-making. In our second example, Mr. Clark is in for follow-up of anticoagulation management and statin therapy. His INR is therapeutic today, and the patient will remain on the current dose of warfarin. There has been no improvement in the lipid profile, and the patient is to increase their statin to 20 milligrams daily. In this example, the provider would receive a total of 3 points in the diagnosis and management options, 1 point for the controlled anticoagulation, and 2 points for the unchanged lipids. Under the amount and complexity of data to be reviewed, we would assign 1 point for reviewing the labs, and under the risk, we again would be directed to moderate because the dosage is being changed on the statin, which gives us prescription drug management. When we applied this example to the medical decision-making section on the auditing tool, we would circle 3 points in the diagnosis and management options, 1 point under the amount and complexity of data to be reviewed, and moderate for the risk. In this example, we have 2 of the 3 elements that meet in the same column, and therefore our medical decision-making is moderate. In our third example, Mr. Hernandez presents for medication management of diabetes, hypertension, and cholesterol. The hypertension and cholesterol remain stable, but the diabetes is mildly uncontrolled because the patient has not been compliant with taking his medication. The provider documents that history is obtained through use of an interpreter due to the patient's limited English. Labs from July 1st are reviewed, and there is a documented decision to obtain records from the patient's previous PCP. Under the diagnosis and management options, the provider would receive a total of 4 points. 1 point would be assigned for each stable problem, and another 2 points for the uncontrolled problem. Under the amount and complexity of data to be reviewed, 1 point would be assigned for the labs, 1 point would be assigned for the documented decision to obtain old records, and 2 points would be assigned for getting history from someone other than the patient. Under risk in our presenting problems, the patient has 2 stable chronic illnesses and 1 chronic problem that is mildly uncontrolled or progressing. This would give us a moderate level of risk. When we apply our third example to the medical decision-making table in the auditing tool, we would circle 4 points under diagnosis and management options, 4 points under the amount and complexity of data to be reviewed, and moderate risk. In this example, we again have 2 of the 3 elements that align in the same column, and our medical decision-making would be high. It is important for providers to remember that high risk is not necessarily needed to obtain high medical decision-making if the work has been performed in the other 2 elements. So let's apply what we learned in this session to our case study, which is more completely documented. Please feel free to work through this with me on the auditing tool provided by WSPA. We see that the patient has hypertension with edema. The goal is to keep the blood pressure under 150/90, and the patient is at goal today. Our plan for this problem is to continue the enalapril at 10 milligrams daily, and refills were written. A BMP is planned for 3 months out, and the patient is to continue to monitor their blood pressure at home with instructions to call the clinic if the blood pressure falls under 100/60. They are to continue to take 20 milligrams daily of furosemide as needed for the edema. Diabetes A1C is 5.4%, and the patient is compliant with metformin. They are to continue the same dose of 500 milligrams twice daily in the AM and PM. Cholesterol is documented as patient has diabetes without clinical ASCVD, and the recommendations per the AHA and ACC 2013 guidelines is to receive a high-intensity statin with the goal of reducing the patient's LDL by 30 to 50%. The LDL was documented as 128 in December 2015. The patient stopped taking their statin due to leg cramps but is willing to try another statin, so simvastatin at 10 milligrams daily is started. Fasting lipids will be repeated prior to their next visit. In our case study, we had a total of 3 problems that we can count under the diagnosis and management options. 2 problems were controlled, which were the hypertension and diabetes. And there was 1 problem that was unchanged, which was the cholesterol. To calculate the total number of points in this element of MDM, we would enter the total number of problems for each category into the numbers column on this table. So we had 2 established well-controlled problems, and we had one established, unchanged problem. And we've entered those numbers into this numbers column. The number that is in the numbers column is multiplied times the points in the points column next to it. So we had 2 problems worth 1 point, and that gives us a total of 2. Under the unchanged or uncontrolled problems, we had 1 problem, which is worth 2 points, and that also gives us a total of 2. The numbers that are in the results column are totaled to give you the total number of points, and in this case study, we have reached 4 points, which is the maximum under the diagnosis and management options. In our case study, the provider documented the patient's A1C and the last fasting lipid profile. They also documented that they would be ordering a BMP to occur 3 months from the date of the encounter. This is work that is credited in the amount and complexity of the data to be reviewed. So in this table, the provider would receive credit for reviewing and/or ordering clinical lab tests, which is worth 1 point, and this is the only work that was documented in this element of medical decision making, so our total in this element is 1. In our case study, the patient presented with 1 uncontrolled problem and 2 stable chronic problems. We also had a prescription that was started for the simvastatin. So if we were to look at the table of risk, we would see that all 3 of the patient's problems are counted toward the moderate level of risk under presenting problems, and our management option of prescription drug management is also counted in the moderate level of risk. So the risk that is assigned to the encounter is moderate. To calculate the medical decision making for our case study, we would use the MDM table in the WSPA auditing tool. We were able to obtain a total of 4 points under diagnosis and management options, 1 point in the amount and complexity of data to be reviewed, and our risk was moderate. Remember that we need to meet or exceed 2 out of the 3 elements, and since we don't have 2 circles that have aligned in the same column, we can see that they have intersected at the moderate level, so this case study would be assigned moderate medical decision making. In the outpatient or office setting, moderate medical decision making would support 99204 if the patient was new, and 99214 if the patient was established. Keep in mind that the other key components will need to be met as well, but the medical decision making for our case would support these E&M codes. In the domiciliary or assisted living setting, moderate medical decision making would support 2 codes in both new patients and established patients. New patient codes could be either 99326 or 99327, depending on how much history and exam the provider also documented. And for established patients, 99336 or 99337 could be supported, again depending on how much documentation was performed by the provider in the other 2 key components. In the home setting, we would also be able to select either 99343 or 99344 for a new patient with moderate medical decision making. For an established patient, we also have 2 options, the 99349 or 99350. For an inpatient hospital setting, moderate medical decision making would support an initial care code 99222 and a subsequent visit code of 99232. In the nursing facility setting, moderate medical decision making would support an initial care code of 99305 and a subsequent visit code of 99309. If a consult was being performed, moderate medical decision-making would support the fourth level in either the outpatient or inpatient setting. The code supported by moderate medical decision-making in the outpatient setting would be 99244, and in the inpatient setting, it would be 99254. Here are my sources for this session. I recommend that you read them for yourselves to have a thorough understanding of the guidelines. If you work for a healthcare organization and have a coding educator available to meet with you, I would encourage you to do so to understand the organization's policies and procedures regarding E&M coding. Thank you for listening to our session on medical decision-making. I hope that it has helped you to understand how the clinical information you document in your progress notes is used to support the levels of medical decision-making as defined by CMS and CPT for the E&M codes.